Screening for vitamin B12 deficiency in Parkinson's disease.
In this presentation, I will cover the following points. First, why to have such a presentation. Second, which indicators are used to assess vitamin B12 status. Third, which Parkinson's disease outcomes these indicators can predict. Peripheral neuropathy, risk factors for vitamin B12 deficiency, and a screening tool.
Why do we have this presentation?
Vitamin B12 deficiency is an important condition which needs to be recognized and treated promptly, as it may result in permanent, irreversible neurological damages. Many of the clinical signs of vitamin B12 deficiency are unspecific and are the same as in Parkinson's. Symptoms may include fatigue, nausea, weakness, numbness, tingling, pins and needles as in peripheral neuropathy, walking difficulty, orthostatic dizziness, irritability, reduced taste or smell, cognitive impairment, depression, paranoia, and dementia. Vitamin B12 deficiency is common in Parkinson's disease. Unlike what many medical professionals believe, neurological symptoms may appear before those of anemia. In fact, the most common clinical manifestations of vitamin B12 deficiency are neurologic or psychologic symptoms. These are much more common than megaloblastic anemia.
Biomarkers.
We have four major indicators of vitamin B12 deficiency: serum total vitamin B12 concentrations, homocystinemia, methylmalonic acid, and holotranscobalamin. The most widely used biomarker for vitamin B12 deficiency is serum total vitamin B12 levels. Vitamin B12 levels are lower in patients with Parkinson's disease compared with controls. However, there is a problem. The problem is that serum vitamin B12 concentrations are not a reliable, sensitive indicator of vitamin B12 deficiency. If we relied only on this test, we would be likely to miss people with a deficiency in which serum concentrations of total B12 are still normal or low normal. Laboratories most often report values in the low normal range as normal values, whilst they may be indicators of borderline deficiency. Factors influencing B12 levels include vitamin A, vitamin C, alcohol, and smoking. When there is vitamin B12 deficiency, serum levels of homocysteine increase. Let's see why. Methylcobalamin, which is one of the two active forms of vitamin B12, acts as a cofactor for the enzyme methionine synthase in the reaction which converts homocysteine to methionine. In this reaction, 5-methyl tetrahydrofolate from the folate cycles acts as a methyl donor. When there is a deficiency of methylcobalamin, the conversion of homocysteine to methionine is affected. This results in the accumulation of homocysteine with an increase in blood levels. At the same time, since homocysteine is no longer converted to methionine, the production of methionine is affected as well. Methionine is important because it's needed for methylation reactions, including DNA methylation. Disruption of methionine synthase activity causes what has been called a methyl trap, a pseudofolate deficiency which plays a crucial role in various cellular functions. As also folate, B6, and betaine participate in homocysteine metabolic pathways, an increase in homocysteine may occur also as a result of deficiency of these other B vitamins. A normal level of plasma homocysteine measurement rules out vitamin B12 and folate deficiency in an asymptomatic patient. Levels of homocysteine may also increase as a result of chronic kidney disease, hypothyroidism, and smoking. Methylmalonic acid is a biomarker of vitamin B12 deficiency, which is specifically linked to vitamin B12. Methylmalonic acid reflects intracellular vitamin B12 status much more accurately than the other indicators we have seen so far. When there is vitamin B12 deficiency, the level of methylmalonic acid increases, and methylmalonic acid levels increase also when vitamin B12 deficiency is mild, vitamin B12 levels are in the normal reference range, and vitamin B12 deficiency may still be subclinical, so no clinical signs manifested yet. Now, what is the role of vitamin B12? One of the two active forms of vitamin B12 is adenosylcobalamin. This acts as a cofactor for the enzyme L-methylmalonyl-CoA mutase in the reaction which converts L-methylmalonyl-CoA into succinyl-CoA, which enters the Krebs cycle with energy production. If there is a deficiency of B12 and therefore of adenosylcobalamin, there is an increase in the levels of methylmalonic acid. Methylmalonic acid levels may rise also in the presence of renal insufficiency, hypothyroidism, and in the elderly. After absorption, vitamin B12 circulates bound to transcobalamin, holotranscobalamin, and haptocholine. Transcobalamin carries a smaller part of the total vitamin B12, something like 6 to 20%, but this is the one which is transported into the cells, inside the cells, and it has therefore been called the active vitamin B12. The test, however, is not yet widely available. Now, levels may increase in the presence of reduced kidney function and liver diseases.
Predictors of Parkinson's disease outcomes.
In Parkinson's disease, vitamin B12 deficiency is associated with peripheral neuropathy, increased walking and balance issues, cognitive impairment, and more rapid progression of Parkinson's disease. In early Parkinson's, it has been found that while low levels of vitamin B12 were predictors of increased gait issues, high homocysteine levels were predictors of increased cognitive decline. Hyperhomocysteinemia is also an independent risk factor for osteoporosis and fractures in Parkinson's. It is common in Parkinson's because of the levodopa use. There is an association between higher doses of levodopa, higher levels of homocysteine, and lower bone mineral density in people with Parkinson's, with a prevalence of osteoporosis higher in people with Parkinson's than in controls. A deficiency in vitamin B12 and folic acid may therefore lead to an increase in homocysteine in the blood. Hyperhomocysteinemia is neurotoxic, is a risk factor for a number of cardiovascular system disorders, and may lead, as we've just seen, to osteoporosis and fractures in people with Parkinson's.
Peripheral neuropathy.
Peripheral neuropathy is very important. Peripheral neuropathy, especially small fiber neuropathy, is much more common in people with Parkinson's than it was previously thought. Rates reported go up to 55%, 1 in 2 people with Parkinson's, compared with 9% in the general population. Neuropathy in Parkinson's disease is often associated with B12 deficiency. Persons with Parkinson's with neuropathy have been found to have markedly lower vitamin B12 levels.
Risk factors.
We have a number of risk factors that we have used to develop the screening tool for vitamin B12 deficiency. The first is age. Vitamin B12 deficiency and subclinical vitamin B12 deficiency are common in the elderly. The prevalence of vitamin B12 deficiency in those over 60 ranges from 10 to 15% and keeps increasing with age. In the UK, the incidence of vitamin B12 deficiency was in one study found to be 24% of adults aged over 65, much higher than in the general population. Now, since most people with Parkinson's are elderly, over 60, they have by definition the age risk factor. The main reason for the increased prevalence of vitamin B12 deficiency in the elderly is that with aging there is an increased prevalence of risk factors for vitamin B12 deficiency. On one hand, we have inadequate intake from the diet. On the other hand, we have reduced absorption of vitamin B12. This is especially due to the high prevalence of atrophic gastritis and the frequent administration of medicines in the elderly. Another condition which tends to affect the elderly more than younger people is pernicious anemia. The prevalence in the elderly over 60 is 2%, much higher than in the general population where it is 0.1%. Being strictly vegan is another risk factor for vitamin B12 deficiency. Over 50%, 1 in 2, of vegans in the European Prospective Investigation into Cancer and Nutrition, the EPIC Oxford study, were found to be vitamin B12 deficient. Adequate amounts of vitamin B12 are in fact found almost exclusively in animal-based foods. Vegans exclude from their diet all animal foods, including eggs and dairy products. They consume a diet exclusively based on plant products which lack vitamin B12. As seen for other groups, they also have an increased risk of vitamin B12 deficiency with aging. Next, we have chronic alcoholism as another risk factor. High and chronic intake of alcohol is also another risk factor for vitamin B12 deficiency by reduced dietary intake and reduced B12 absorption. Medicines are an important risk factor for vitamin B12 deficiency in persons with Parkinson's. Carbidopa-levodopa is a medicine which is widely used to control motor signs in Parkinson's. When levodopa-carbidopa is given at high doses and for a long time, levodopa can reduce vitamin B12 levels and increase homocysteine levels, in this way causing neuropathy. Levodopa gel infusion can also cause vitamin B12 deficiency. Metformin is one of the most widely prescribed drugs in the world. A large body of evidence suggests that patients with type 2 diabetes mellitus treated with metformin are at risk of developing vitamin B12 deficiency over time. This is due to the reduced absorption of vitamin B12 caused by metformin. The risk has been related to both the duration of the therapy and the dose. Proton pump inhibitors are medicines which are very commonly prescribed also in general medical practice. These medicines are used to reduce stomach acidity in conditions such as gastroesophageal reflux, peptic ulcer, Helicobacter pylori infection, gastrinoma, and so on. Some of these conditions are very common also in Parkinson's disease. Vitamin B12 absorption process initially requires the presence of an acid environment to enable the release of the vitamin from food proteins to which it is bound. So, in situations where the gastric environment is no longer acid, like what we find in atrophic gastritis, in subjects treated with the proton pump inhibitors, in gastrectomy, in these situations, dietary vitamin B12 is no longer freed from food. Also, PPIs, the use of these medicines, is associated with vitamin B12 deficiency. In a study in a hospital geriatric unit, patients receiving calcium supplementation together with gastric acid inhibitor, PPIs, were found to be less likely to have vitamin B12 deficiency if they were taking the supplementation of calcium. Lastly, we have a series of gastrointestinal conditions with B12 malabsorption, which are risk factors for vitamin B12 deficiency. Let's have a look at some of these conditions. Atrophic gastritis is present in 10 to 30% of people with Parkinson's over 60 years old. It results from a chronic infection of Helicobacter pylori or is a result of autoimmunity. It leads to reduced production of gastric acid and pepsin, and the reduced acidity of the gastric environment leads to B12 not being freed anymore from food, and also leads to the lack of the natural barrier to bacteria, which then can result in the small intestinal bacterial overgrowth or SIBO. SIBO is very common in Parkinson's. 1 in 2 people with Parkinson's are likely to be affected by it, according to some reports. It may be a consequence of proton pump inhibitors, which lead to excessive growth of bacteria in the intestine. Gastroesophageal reflux disease is very common also in people with Parkinson's, 1 in 4 in some reports. It is associated with high unified Parkinson's disease rating scale scores, and is also a condition in which proton pump inhibitors are often used, and we have seen that those are a risk factors for vitamin B12 deficiency as well. There is a high prevalence of Helicobacter pylori infection in Parkinson's. The infection leads to a marked reduction in B12 levels. It is associated with worse UPDRS scores, and it has been seen that its eradication leads to clinical improvement and increase in B12 levels. There are then a number of other conditions, like those caused by surgery, for example, gastrectomy, the removal of the stomach, which takes away the acid environment, which enables the freeing of vitamin B12 from protein food, and that acts as a barrier to bacteria, therefore increasing the chances of development of a small intestinal bacterial overgrowth. Also, the removal of large portions of small intestine, where absorption of vitamin B12 takes place, may lead to vitamin B12 deficiency. In general, intestinal malabsorption syndrome for B12 and pernicious anemia.
Screening tool.
Let's now have a look at the screening tool after having gone over the major risk factors for vitamin B12 deficiency in Parkinson's disease. The physician can start asking 6 screening questions. First, are you 75 years old or older? We have seen that the risk for vitamin B12 deficiency increases with age and is much higher at the age of 75 or older. Second, do you have numbness, tingling, stabbing, sharp pain, pins and needles at hands or feet? This suggests the possibility of the presence of peripheral neuropathy at the extremities. Third question, are you vegan and not taking any B12 supplements? We have seen how this is a risk factor for B12 deficiency as well. 4. Do you have a chronic high alcohol intake? 5. Are you taking levodopa, metformin, or proton pump inhibitors? 6. Do you have any of the following conditions, or have you been found to have any of the following conditions, such as atrophic gastritis, SIBO, gastroesophageal reflux disease, Helicobacter pylori infection, gastrectomy, malabsorption, inflammatory bowel disease, pernicious anemia or anemia or macrocytosis? If the answer to any of these questions is yes, then laboratory tests are needed to confirm the suspicion of vitamin B12 deficiency status. We can currently think of 3 possible scenarios based on the availability of tests in the laboratory which is accessible. The laboratory can test only vitamin B12 levels. The laboratory can test also homocysteine but not methylmalonic acid. And third, the laboratory can test both homocysteine and methylmalonic acid. The first scenario is the one where the laboratory can test only B12 levels. We go ahead, we have vitamin B12 measured, and while waiting for laboratory results, if the patient has symptoms suggestive of peripheral neuropathy, the physician may consider starting a combination of vitamins B, such as B12, B9, B6, B2. If the values reported by the laboratory are in the range of 111 and 294 picomoles per liter, this suggests the presence of a borderline vitamin B12 deficiency, and this would require, if possible, further evaluation through other tests, for example, methylmalonic acid. If the values are less than 111 picomoles per liter, this suggests a clear presence of vitamin B12 deficiency. If the values are equal to or greater than 295 picomoles per liter, vitamin B12 deficiency is most unlikely. The second scenario includes the situation where the laboratory tests vitamin B12 levels and also homocysteinemia. We go ahead and we measure homocysteinemia. If the homocysteine levels are less than 15 micromoles per liter, we may conclude that vitamin B12 deficiency is most unlikely. If the levels are 15 micromoles per liter or higher, vitamin B12 deficiency is possible. Lastly, if the laboratory can test both homocysteinemia and methylmalonic acid, first we measure homocysteinemia. If the levels of homocysteinemia are equal to or greater than 15 micromoles per liter, then vitamin B12 deficiency is possible, but we don't know yet whether the increase in the levels of homocysteine is due to B12 or other B vitamins. We measure methylmalonic acid for confirmation, as methylmalonic acid is very specific for vitamin B12. If the methylmalonic acid levels are not elevated, we conclude it is not vitamin B12 deficiency, the reason for the increase of homocysteine levels. But the increase in homocysteine levels may be due to a deficiency of other B vitamins like B9 or B6. If the methylmalonic acid levels are elevated, we then conclude that the patient has B12 deficiency.